Hi, this is Brian Kim. I want to share with you this case of a patient who had a dislocated IOL, and then I replaced it with a Yamani AR40 lens using my technique. But then post-operatively, the patient had a pupillary capture of the optic. And I don't say this to brag, and this is not hyperbole. I might have had one case of pupillary optic capture when I was learning how to do this early on, but this is my very first pupillary optic capture as an experienced Yamani surgeon. I pushed the optic back with the needle at the slit lamp. I did another PI thinking that it was reverse pupillary block, but it kept capturing. I'm going to go through why this happened, why I thought it happened, how it happened, why I have this tilted lens and a pupillary capture of the optic. And I'm going to show you footage from the first surgery, and you're going to see it really doesn't look that bad. I feel like I executed it pretty well, but you're going to see why and how this happened, how I fixed it, and the most important point in this video is a really great educational video that every detail matters. And so you can see this is the eye. This is a huge eye. This patient has a huge pupil, long axial length, reduced scleral rigidity. And so you can see that the lens is pretty well centered, and you can see that the haptics are nice and flat on the left and the right side. You can see the nice haptic orientation. It's flush to the sclera, which means from an anterior posterior perspective, it seems fairly well positioned. But this is what is important. If you look really closely, you can see the haptics right here. The right side haptic is nice and parallel to the limbus, but the left side haptic is not parallel. And I'm going to show the footage from the first case. It's so subtle, but as I'm advancing the left side needle, I'm kind of tunneling the needle a little bit more anteriorly towards the limbus, and that's why it emerges closer to the limbus and it's higher inside the eye. And because it's higher towards the iris, the pupillary capture of the optic is occurring, which is temporal. And so that's the important point. And how could this happen? I've been executing the right side needle the same exact way, but as you may recall, I've been executing the left side needle a little differently. And here is the footage from the original case. The thing I've been doing differently is I'm holding the eye contra-incisionally with the forceps, and I'm tunneling to keep the eye in the neutral position. But you can see here the execution didn't look that bad. But what must have happened is I must have turned the needle a little bit towards the limbus. And you can see that optic capture right here. You see that optic capture. I thought, okay, that's not a big deal. It's probably just because of the fluidics. I'll just pop it back and I'll be fine. But again, if you look at the execution of the tunneling of the needle through the sclera, it looked pretty good. But I must have, which again, it has to do with the angle, and because I'm holding the forceps contra-incisionally, that I'm ending up a little bit turning the needle too prematurely. Instead of pointing it straight up and down and pointing towards the nerve, I'm kind of turning it towards the limbus, and then I dove down, and that's why you have that orientation of the left side haptic that's not quite parallel to the limbus. And because it's not parallel to the limbus, it's causing that haptic to emerge through the sclera more anteriorly, and because it's more anterior, I'm getting that pupillary capture of the optic temporally. This patient also ended up a little bit more myopic, and so rather than just repositioning this lens, I decided to remove this lens and replace it with a different lens, a slightly lower powered lens. So I'm making my incision on the right side, and then the left side, the incision from my AC maintainer, and then that last incision contra-incisionally to externalize the leading haptic. This is simply a 27 gauge needle, and I punctured through the conjunctiva right over the area of the haptic on the right side, and then I'm very carefully trying to pick at the haptic and lifting it up. So a couple of observations. That haptic is really buried very well underneath the conjunctiva and sclera. There's no way that haptic was going to extrude. It has such a nice flat profile. It was embedded deep into that superficial sclera, and it took me a while to kind of pick at that haptic tip, that flange. And so you can see I'm using the cotton tip to remove any blood, and then I'm able to get that needle underneath that flange and pop it up. I'm doing the same thing on the left side, using the cotton tip to hold the eye, and then I'm just cutting using the needle through the conjunctiva right where I see the haptic. I'm just creating a little defect in the conjunctiva right in that area, and then very carefully teasing the bulb up. Again, look at the good position. And it's because I have a nice scleral shelf and the haptic tip is embedded into the sclera. That is not going to extrude. So I pull that tip up with the needle. I push some dispersive viscoelastic to protect the corneal endothelium. And this is the 3/0 blade, the triplanar corneal incision with the blade. Grasping the tip of the flange, cutting it, and then using microforceps, I'm going to pull the leading haptic into the eye and popping it into the angle. And I'm going to do the same thing on the right side, grasping the flange, cutting the flange with micro scissors, grasping with the serrated IOL holder on the left side, and then carefully using the smooth forceps on the right hand and popping the trailing haptic into the angle as well. Now I have both haptics into the angle. I switch to the IOL cutter and very carefully bisect the lens in half. Because I don't want to lose the lens, I'm going to cut the lens about 90%, and then using two forceps, switching to the smooth here, grabbing the cut edge of the optic on the right side, pulling it out such that the haptic also comes out, and then I'm very carefully Pac-Manning it and rolling the optic in such a way that the second piece comes out. And I'll go ahead and hydrate the incisions here. Again, this patient's had multiple retinal detachments, and I've also did a vitrectomy on the original surgery. There's no vitreous here. So that's why I'm not doing vitrectomy. I'm not doing those extra maneuvers. So all I'm wanting to do is fill the anterior chamber, make sure the eye is nice and firm, and then I make my marks. I ink the tip of a 27 gauge cannula, inking the right side, and then 180 degrees on the other side, inking the limbus as well, using the Wexel sponge to dry the surface, which is very important with this technique. And this is a fixed caliper from Epsilon. I don't have any financial interests. I'm indenting the sclera 2.5 millimeters posterior to that limbal mark in radial fashion, and then 2 millimeters adjacent, and then using the tip of that inked cannula to mark those indentations. Doing the same thing on the left side, making sure it's dried with the Wexel sponge, indenting with the fixed caliper 2.5 millimeters posterior to that limbal mark in radial fashion, and then 2 millimeters adjacent, and then making sure that I dry, and then inking those indentations. And those are my landmarks for the Yamani technique and the way I do it. This is a 22 gauge thin-walled AC maintainer from Epsilon. Again, I don't have any financial interests. I was very cautious to use the AC maintainer because I didn't want any conjunctival ballooning, but you're going to see I don't have any issues with that. And I think it's because I had such a nice scleral shelf, a good tunnel. That's the 25 gauge needle. I'm bending it fairly close to the tip, making sure the bevel is facing to the right. This is the right side needle, bending 9 millimeters from the tip, making sure I angle it in such a way that the bevel is going to face the main incision. And this is the left side needle, bending at the hub, making sure that the bevel is facing the contralateral limbal incision. So I am ready to go. And this is the cartridge for the AR40 lens, and this is the J&J cartridge for the Sensor AR40 lens. Push some cohesive viscoelastic on the cartridge, placing the lens into the cartridge, making sure the optic is seated down, pushing down, and then bringing the wings together, making sure the optic bends concavely, which is backwards, making sure the leading haptic goes through the barrel, forward, and then the trailing haptic goes out to the back end, sliding the cartridge into the injector, making sure that the trailing haptic is outside the barrel, and I push the plunger and I'm ready to go. This is a 25 gauge needle. Again, it's mounted with BSS, so there's no bubbles. I go in, the bevels are facing each other. The needle bevel is facing to the right. The injector bevel is facing to the left. My assistant is advancing the lens. You see that I had a little slip there, but then I go ahead and reposition and dock the haptic on the bevel of the needle. She advances the lens and the haptic is more internalized into the 25 gauge needle. I pull the needle out and passively the leading haptic is externalized, deliver the rest of the lens and leaving the trailing haptic out, pushing some dispersive viscoelastic to coat the cornea and protect it, holding the incision with the forceps, turning on infusion, stabbing the conjunctiva sclera at the first mark, tunneling 2 millimeters, staying nice and flat, and then diving down. I have tremendous confidence on my right side needle and how I execute it. And so I'm not really worried about that tunnel. I know it's a solid tunnel. I'm pulling the leading haptic out more in order to position the optic further away. My AC maintainer is getting caught up on the optic. I want to make sure the optic is underneath the AC maintainer. And now I'm in better position. The optic is pushed away. The AC maintainer is on top of the optic. And this way I have better access to that trailing haptic. So I'm just do a sideways slide technique so I don't bend and deform that haptic. And then with infusion on, I dock the haptic on the bevel of the needle and 2 pushes, and then I'm in. Again, very easy. And this all has to do with alignment. A very subtle point, but a very important point. Disengaging the needle from the syringe and laying it down. Internalizing the leading haptic with microforceps and placing it into the angle. And this is a difference. This subtle difference is what makes or break the technique here. And so I'm going to hold the incision contra-incisionally with my forceps. And as I stab the conjunctiva and sclera with the 30 gauge thin wall needle, I'm going to make sure I'm flat, but I'm going to dive towards the nerve and not towards the limbus. You saw that? Very, very subtle. I was very intentional about diving towards the nerve. I tunneled through the sclera, stayed nice and flat, went 2 millimeters. I dove towards the nerve. If I dove towards the limbus, then I would have had not quite that parallel angle of the needle and the haptic track. And so now I'm able to dock the haptic on the bevel of the needle, 2 pushes, and I'm in. I go ahead and pull that left side needle towards me, and then I'm able to grasp the leading haptic, cauterizing the tip. It slipped in my hand there, so I got a little bit of the conj there, but that's okay, not a big deal. And then I'm pulling the right side needle away from me. Again, that's because that's the direction it came from. I have the microforceps ready to grasp the haptic as it comes out, and you want to limit how much that haptic comes out. Limiting how much the haptic comes out minimizes any stress on the haptic-optic junction. And then I turn off infusion, and then I cauterize the tip. And now you can see I have symmetrical, parallel, flat orientation of the haptics right here. So you see that? Nice and flat, but more importantly, because I'm pretty good about making sure I have a nice scleral tunnel, but look at how flat it is and look how parallel it is. Now compare that to the other case, the first case when I did it, you saw that left side haptic was more kind of angled towards the limbus. This time you can see the haptic is definitely more oriented parallel, and that's because I dove towards the nerve and not towards the limbus. Again, such a subtle distinction. Most people, when they're doing this and looking at this and they don't do Yamani, they're going to really have no idea what went wrong. But in this case now, because I dove towards the nerve, I can see the optic is definitely seated in a more posterior position. It's more away from the iris. And definitely, I feel a lot more confident that I'm not going to get pupillary capture of the optic. Go ahead and place a 10-0 nylon suture. I'm doing this in 8x speed just to go through it. And then after this, take the AC maintainer out, and then I'll hardget my incisions, and this is the end of the case. And so again, if you have a Yamani that's not right, since I did the original surgery, I knew what I was getting myself into. One of the learning points is if you do execute the technique pretty well, as far as making sure you keep a nice flat approach and you get a good scleral tunnel of your needle, you're going to get a nice scleral shelf, and it will allow that haptic to sit nice and flat on the scleral surface. But it also means that flange, that bulb is going to be really, really flat and down, and the chance of extrusion is really going to be very low, as you've witnessed. It took me a lot of effort to use that needle to get that flange up. I had to cut again with the needle, but by doing it that way, I didn't actually do a peritomy, which would have been a bigger surgery. In this case, I don't have to suture those incisions because it was such a tiny little puncture mark. So I just punctured through the conj right over the haptic. I was able to get under the flange of the haptic and pop it up on either side. I cut the flanges, internalized each haptic, put the haptics into the angles, cut the haptic about 90%, and then I Pac-Maned the lens out. And then I was very intentional. Again, the right side execution of the trailing haptic, I'm very confident. I don't have trouble with that one. But ever since I started grabbing the contralateral limbal incision, I've had to change my trajectory of my scleral needle pass on the left side. And before, because the eye would rotate away from me because I wasn't holding it contra-incisionally, I didn't have that problem. But now, because I'm holding that incision contra-incisionally, it's so much more important that I'm intentional about diving down towards the nerve, which I did in this case, and the lens was in a much better position, and I was able to fix this pupillary capture of the optic in my Yamani case using the AR40 lens. So I hope this was helpful to you, and I thank you for your attention.